Good evening, everybody, and welcome once again to the ICS webinar series. Today, as you are aware, we are having a discussion on tuberculosis, covering both drug-sensitive TB and drug-resistant TB. Me, on behalf of myself and the panelists, let me start by thanking the entire ICS team, Dr. Rakesh Chawla, Dr. Amita Nene, and Dr. Radha Munje for having taken up tuberculosis on the eve of World TB Day. As you are aware, World TB Day is coming up on March 24, and all of us at our levels are doing various programs for TB, and I'm so happy that ICS, particularly Dr. Amita Nene, has taken the lead. Of course, it's her favorite topic, tuberculosis. So she has taken the lead, and we have a eminent group of faculty panel with us today, and we will be going ahead with the program. So our program starts today with a talk on the newer regimes, the BPAL and the BPAL-M regime by Dr. Vikas Oswal. So let me put up Dr. Vikas' slide, please. So Dr. Vikas Oswal is, well known to all of us who work in the field of tuberculosis. I'm sure that all of you know him very well. And Dr. Vikas is the go-to person with respect to the newer regimes, with respect to, bedaquiline and other newer drugs. He is our go-to person for private sector involvement in NTEP. And he has been a past member of our National Technical Expert Group. He is part of various global fora in the field of tuberculosis. And also he has been part of, as a researcher, he has been part of the BPAL and the BPAL-M various trials. So he comes in with both clinical experience while working in Mumbai with these newer regimes, and also with research and scientific experience with respect to all these newer regimes. And you can see his entire CV there. I'll not take too much of time reading through the entire thing, but he has been doing excellent work in Mumbai and for the entire country, and in fact for the entire world in the area of tuberculosis. We are so happy that he's there with us to talk on a topic on which he has both clinical experience as well as research experience. So over to you, Dr. Vikas. We can start with your presentation.
Thank you. Thanks a lot, sir, for the kind introduction. First of all, thanks a lot, Indian Research Council, for taking an initiative again on behalf of this World DB Day, a webinar on tuberculosis, which is much required a topic, Yeah. So this has always been my first slide, not an obsession, but a message over here that each and every sector needs to get collaborated together, have a collaborative efforts if we really want to win this battle against tuberculosis. Let it be a private sector or a public sector or an NGO. Everybody working, each and every sector working against tuberculosis needs to join hand together to fight this smart bug that is tuberculosis. Yes, what's new in diagnosis and treatment at present? Well, NTEP, we have come up a long way, right from the alternate regimen in India to the daily regimen, and then from 24 months of regimen to 18 months injectable, and then from there now to 9 to 11 months of regimen, and now only 4 pills, that do for 6 months of regimen. So let's just cover exactly what's new right now and what's the latest in tuberculosis. We all know the past. Well, we all are aware of it. At present, we all know that yes, there is a shorter regimen of something called as BPAL. So we will just deep dive into the same and see exactly what all things are going on. Well, this was the last guidelines 2021, which we used to follow, where the injectables were been replaced to the longer regimens, oral longer regimens. That is, bedaquiline based all oral longer regimens were being followed in this particular guidelines of 2021. This is the algorithm which we all know. We are aware of this algorithm, where each and every sample suspected, suspicious of tuberculosis, we used to send for NAT, that is nucleic acid amplification test. And depending upon the report, whether it is RIF resistance which is present or RIF resistance which is absent, depending upon this, the further reflex test of first line LPA and a second line LPA used to go along with the MGIT culture and DST. And then depending upon the further report, we used to categorize the patient whether they need only FDCs or whether do we categorize them particularly as H resistance if there is presence of H resistant on first line LPA, or whether the patient can be treated with a shorter regimen or do require a longer regimen. So this was an old algorithm, where we had this 4 regimens, that is DSTB regimen, H monopoly regimen, then shorter BDQ based regimen, and a longer bedaquiline based regimen. So we are aware of Gene Expert. That is, Gene Expert now was been shifted to Gene Expert Ultra, and now in field, each and every Gene Expert almost everywhere we have been shifted to Gene Expert. That is TrueNAT. That is chip-based TrueNAT Gene Expert, just because it's made in India and from India, right? That is by MolBio. Well, something to just a small quick review for a Gene Expert, the cartridge-based test, where each and every sample except for the blood or maybe even stool and urine are not to be sent in this Gene Expert test. The NAT test all of the samples can be sent for Gene Expert upfront, and you get the report in just 2 hours. But considering all the logistics of bringing the sample, taking out the sample, collecting the report, generating the report, and handing over the report, maybe you can just consider around 2 to 3 days period. But otherwise, the test takes only 2 hours to diagnose whether MTB is present or absent, and if it is present, whether rifampicin resistance is present or absent. Similarly, immediately after Gene Expert comes the LPA first line, where we can categorically see the mutation on H for isoniazide, that is INHA mutation or CATG mutation, whether it is present or absent, which will give us further information whether the patient can be continued with isoniazide or whether do we need to replace isoniazide with quinolone group of drugs. Well, similarly, this is a Gene Expert report suggesting of MTB which is present over here and rifampicin resistance. So this is a patient of, yes, this is MDRTB patient. And the moment you get a Gene Expert MTB present, rif resistance present, directly think of, yes, this patient will require a second line drugs. This is a report of first line LPA where rifampicin resistance is detected over here and isoniazide resistance is detected over here. So this is HNR resistant, a pure MDRTB case. This is the second line LPA report where FQ is showing resistance which is present over here, and second line injectable, that is kanamycin, amikacin, kepremycin, all 3 of them resistance is absent over here. That means, yes, this case is now not only MDR, but it's a pre-XDR-TB case where quinolone group of drugs are not working for this patient. Well, the moment you get Gene Expert report as MTB present, rif resistance present, that is rif resistance detected, immediately think and collect the second line LPA report. Second line LPA report will further tell us whether the GYRE A mutation is present or absent. Just check for the mutation, which gene codon the mutation is present. If there is a mutation somewhere present on GYRE A, that is mutation 1, 2, 3A, anywhere on this 3 gene codon, levoflox is of no use for our patient. We need to shift the patient on moxiflox high dose. But if there is a mutation which is present further on 3B, 3C, and 3D, none of the quinolone, even high dose moxi, is of no use for our patient. We will have to shift our patient from quinolone group of drug to other replacement drug. Well, this is about the second line LPA report where you get information about the quinolone group or second line injectable group. And first line LPA gives you information about rifampicin, isoniazide, and also etonomide, depending upon the INHA mutation present or absent. This is the third test which is present as MGIT culture. This is a machine, and these are the tubes where the red flag, once the MTB is present and grown in the test tube this way, maybe after 3 weeks period incubation or maybe 6 weeks of incubation, this is the fluorescence which has been picked up by the machine, and the machine flags that yes, there's the growth in the particular isolate. The moment the growth is present, this is the report which has been generated as MTB complex isolated. Now, I'll take 2 seconds on this slide. The moment we have an MGIT culture positive, that means mycobacterial tuberculosis complex isolated. The moment we have a positive MGIT culture, and if we fail to send a further requisition form for second line DST, all our efforts are going to go in vain. So if the patient sample is in private sector, we need to send a requisition letter for doing or carrying out further DST after MGIT culture is positive. And which is not same for the public sector. If the sample is gone in the public sector, there is a reflex test, that is after Gene Expert, immediately LPA is carried out. After LPA, first line, second line, immediately the culture has been set. The moment the culture comes positive, the DST has been taken care and carried out. So you don't have to send a requisition form. The sample has been sent in the public sector. And if it is in the private sector, we need to send a requisition form for doing further DST. And if we fail to send a requisition form for our patient, we won't be able to justify a regimen of the treatment, because at present in field, what we are seeing is very weird pattern of resistance. That is, most of our patients are pre-XDR resistant to quinolone group of drugs. Not only that, nowadays we are also having bedaquiline resistance and linezolid resistance. Linezolid resistance was less than 2% all over India, but now at present, currently, even linezolid resistance is on rise. This is how you get a DST report of all 14 drugs, each and every drug showing resistant or susceptible once you sign a requisition form for the culture isolate positive report. Well, so the moment you get a report of RIF resistance, these are the group of drugs for second line drugs: Group A, Group B, Group C. Group A, quinolone, bedaquiline, linezolid. Group B drug, clofazimine and cycloserine. Rest all other drugs comes in Group C drugs. The moment we get as RIF resistance detected, what we used to do, we used to just enter Group A and Group B drugs and give a regimen, make a regimen for our patient and give them for 18 to 24 months. That is either leoflox, bedaquiline, linezolid, clofazimine, cycloserine. The moment we get a RIF resistant report, this was the regimen which we used to offer to our patient. And then we used to see for second hand LP report. The moment second hand LP report used to tell there is no Gary A, Gary B mutation, the same regimen is to get continued. If there was a mutation present on second hand LP report, that is mutation which is present on 122A, the leoflox won't work. Patient will need moxiflox high dose. Suppose the mutation is present on 3B, 3C, 3D, even moxiflox high dose will be of no use. Need to shift this drug, that is delaminid, up in the regimen. Regimen becomes delaminid, bedaquiline, linezolid, clofazimine, cycloserine. So if there is a non-availability of delaminid in our area, then the next drug replacement sequence is amikacin over here. Regimen will become as amikacin, bedaquiline, linezolid, clofazimine, and cycloserine. Well, this is all about the longer regimen. But yes, now this was an old guideline, March 21. But now we have come up to a March 20, the recent December 24 guidelines, which we have rolled up in the entire India. So initial guidelines, we used to offer 8 to 24 months of regimen of around good 16 to 18 pills per day, which is now reduced to only 6 pills per day for a period of just 6 months and an extended period, if required, of around 10 months, which is a real fantastic thing which we have offered for our patients. Well, these are the group of investigations which are there in the field. Mark my words, one, that is XDRTB. This is not present under the algorithm, under the NTP program, but yes, it is available and it is well recommended and well recognized by even WHO. So XDRTB cartridges, nothing but same like Gene Expert cartridges, where we get to know the information about the ethionomide, isoniazide, and quinolone drug of group, second line drug of injectables. So you get information of all second line drugs along with isoniazide and ethionomide, except for rifampicin, all other group in XDR-TB cartridges. It will take just maximum 2 days for the report to come. Cartridge-based test, where the DNA has been picked up, PCR technique replication happens, and once the PCR replication has been taken care, the cartridge, the expert machine, the color codon machine immediately gives you an information which drug group of drugs are working and which are resistant. Well, let me repeat, XDR-TB cartridges is not available under the NTP program, but very soon it may be available. It has been included in the new guidelines also, but not yet been rolled out in India. So these are the group of drugs, that is isoniazide, quinolone, second-line injectable, and ethionomide in a one single test. And the moment you get information of all these drugs, trust me, managing or making a regimen at the earliest for our DRTB patient is really very good. And the sensitivity, if you see the picking up of the resistance pattern or mutation is really high as XDR-TB cartridges. That is more than 99% for all group of drugs we can see. Well, next group of investigation, that is NGS, target genome sequencing. Even this test is not there under the guidelines, that is not rolled out in India under the NTP program. But yes, it has managed to make a space in the new guidelines, but not yet been rolled out. They are still under the bargaining phase, where they are going to bargain and make it available very soon, free of cost for Indian population. But the problem, it is well available in the private sectors. The only problem, the challenge is the cost of this test. The target NGS and the whole genome sequencing, both are available in the field, but both are equally costly. That is around 10,000 to 18,000 bucks for per test. So if the patient is affording, then yes, you still can think of asking for a target genome sequencing. This is a next test, that is WGS. Even this test is not present under the NTB program, but yes, very well available in a private market. Right now, we are not using this for making a regimen or changing our regimen for changing the drugs in the regimen under the NTB program, used for a surveillance basis for now. Well, this is all about the old algorithm and the old practice. What we have done is this is a new algorithm and the new regimen. The first part is the same. Suspicious of tuberculosis, let it be any sample, the sputum, gastric lavage, bowel, renal biopsy, or maybe bone biopsy, vertebral biopsy, pus, lymph node biopsy, skin biopsy. Any test where you're suspecting tuberculosis, send it for NAT investigation. The moment it is sent for NAT, and they get it done, whether it is MTB which is present or MTB resistance which is absent. If there is MTB resistance not detected, means it is, if it is sensitive, then immediately they send for first line LPA to rule out further H resistance. Till here, the algorithm remains the same. Now there is a change over here. The moment it is H resistance which is present on second line LPA, immediately the next second line LPA is been sent to further see the change in the quinolone drug of group, whether it is present or absent. Till here, things are still same. And now the thing is the new which has come up on the left arm of the algorithm. The moment the present of gene expert showing acid resistance which is present, directly check for the age of the patient, whether it is less than 14 or more than 14. If the patient is less than 14, do not think of BPAL-M. If it is age more than 14, please think of BPAL-M. The moment it is TB resistance detector on gene expert, age more than 14, the next thing what we need to see is the site of the site, whether it is only pulmonary or whether is it pulmonary with a lymph node or pulmonary with pleural effusion or pulmonary with CNS or port spine. So if there is an extent, if there is dissemination of tuberculosis, do not think of BPAL-M. If it is only pulmonary with only lymph node, you can think of BPAL-M. Only pulmonary, can think of BPAL-M. Extensive pulmonary, can think of BPAL-M. Bilateral cavitatory, can think of BPAL-M. But miliary tuberculosis, do not think of BPAL-M. So, mean to say is, if there is an extensive involvement of more than 2 non-contiguous sites, do not think of BPAL-M. If it is only one single or at the max 2 non-contiguous sites, then yes, you can think of BPAL-M. Okay, so now what if the patient is not eligible for BPAL-M? Then think of a shorter regimen, that is bedaquiline-based regimen, where ethionamide has been replaced with linezolid over here for a period of 2 months. And if the patient is not eligible for both the shorter regimens, the only thing what is left for our patient is the nothing but all longer regimen, which is already there in the field at present. So yes, these are the 4 regimens. First is the 6 to 9 months of BPAL-M shorter regimen. Second is the 9 to 11 months of shorter regimen, where bedaquiline is been given along with the linezolid and not along with ethionamide, which was there as an old practice. So the new practice, ethionamide has been replaced with linezolid, and you can offer this shorter regimen for our pregnant female also. Next is the 18 to 24 months of longer regimen, which is same. 6 to 9 months of H monopoly regimen, which is still the same. The moment it is showing acid resistance on gene expert, immediately think of second line LPA and offer this BPAL-M. Well, now to talk something about the shorter regimen of BPAL-M, how and from where did it come? Well, NICS TB trial was the base of all these trials, in which has also been conducted in India. What did NICS do? NICS gave a 1200 milligram of linezolid along with bedaquiline and pritomanid for a period of good 6 months, and the outcome were being seen. The outcome were equally good for more than 90 to 93%, which was really good. But the problem was only of linezolid induced peripheral neuropathy, a severe toxicity, because the linezolid dose was 200 milligram. Then what Genix did? Genix, what they did was they studied let us study for the dose of linezolid. Instead of only 200 milligram, what they did was they also had 2 arms of just 600 milligrams of linezolid for a period of 6 months. But if you see the outcome of this 600 milligram linezolid, it was equal as 91%. Now this report, this arm of 91% of 600 milligram linezolid of arm 3 having a good, better outcome in Genix trial became a base of our Indian BPAL-M trial, that is modified BPAL trial. And then we also came up with this regimen in India, that is bedaquiline, pritomanid, linezolid, and moxifloxacin. We came up with an MBPAL trial studying further the dosages of linezolid. Instead of giving only 600 milligram rifampicin throughout the period, let us now further study for 6 months and 3 months was the motto of these 13 sites, where even Mumbai was one of the sites in India where we had contributed the maximum from 2 sites, that is Saroj Charitable Trust from Ghatkopar and Govandi site, which was under me being a PI over there. This was the paper, research study paper, which was been published. And finally, after this study, the BPAL-M was been rolled out in India, all over India. Well, if we see the cure rate of all 3 arms in this MBPAL study, we had a good cure rate of 93%, 92%, and 92%, which was a good cure rate. And yes, finally, what we did was this arm 1, which had a 600 milligram of linezolid throughout the period of 6 months, and bedaquiline piperacillin dose remaining the same, was being finally picked up, chosen, and rolled out in India. So yes, what we did, we offered for BPAL-M regimen for India, where bedaquiline has been given for 400 milligram for first 2 weeks, and followed by 200 milligram for Monday, Wednesday, and Friday for total period of 26 weeks. Followed by a piperacillin, which is 200 milligram, one single pill for 6 months of period, and linezolid 600 milligram for entire 6 months of period, no dose reduction unless required, and moxifloxacin 400 milligram once in a day for total period of 6 months. Now, in this, there is a provision of reduction of dose from 600 to 300 milligram, but beyond 9 weeks. So, if the patient has cleared 9 weeks period taking this dose of BPAL-M, and if patient is having some side effects related to, say, linezolid-induced toxicity, we have the consideration of reduction of dose from 600 to 300 milligram, right? And if the patient is having, say, moxiflox-induced toxicity, we still can withdraw moxiflox from the regimen and continue only with bedaquiline, piperacillin, and linezolid. But if we are reducing the dose of linezolid from, say, 6 months, 600 milligram to 300 milligram, the regimen will get extended to 9 months, total 10 months of period, first thing. And if we withdraw moxiflox from the regimen because of side effects, we have to extend the entire regimen from 6 months to 10 months of period. Now, the most important point, even if the LPA is showing as FQ resistance, do not withdraw the moxiflox from the regimen. Let moxiflox be continued in the regimen. Is what is all about this regimen. Right? The moment it is showing as HREZ, which is sensitive, check for the INH resistance. If there is INH resistance present, then just offer leoflox, rifampicin, ethambutol, pyrazinamide to our patient. The moment it is showing RIF resistance, check for the age of the patient. If it is more than 14, offer for BPAL-M. Check for the site of the patient, whether the patient is having only pulmonary, or is there no involvement of CNS or port spine or pericardial effusions or pericarditis, right? So in extensive disease, do not offer BPAL-M. In just pulmonary extensive disease, you can offer BPAL-M, no problem at all, right? But we also need to see whether the patient was not being exposed to bedaquiline, piperacillin, or linezolid or moxifloxacin for more than a month's period, right? So suppose the patient is not eligible for BPAL-M, the next regimen you can think of bedaquiline, leoflox, linezolid, clofazimine, cycloserine, pyrazinamide, ethambutol, and high-dose INH for a period of 4 to 6 months, followed by 5 months of leoflox, clofazimine, pyrazinamide, and ethambutol. So this is our second shorter oral BDQ-based regimen. If the patient is not eligible for both the regimens, then we have to offer longer regimens. This is all what we have covered right now. 14 years of age, more than 14 years, very important. Should be only pulmonary, very important. Should not be exposed to more than 1 month of any of these drugs like bedaquiline, linezolid, piperacillin, very important. QTC should be in the normal range, 450, lesser than 450 in males, lesser than 470 in females. Because as we all know, bedaquiline has a problem of QTC prolongation. You cannot give this drug. Well, patient, if it is lactating female, we have to counsel our females, do not lactate, give only oral feeds. If the patient is not willing to, we cannot offer BPAL-M for our patient. Pregnant female, do not offer BPAL-M. So these are the do's and don'ts for BPAL-M. If the patient is having cardiac toxicity, underlying cardiac problems, do not give BPAL-M. If the patient is having QTC prolongations, please rectify the QTCs by electrolyte imbalances if there is present of electrolyte imbalances, correction of electrolyte imbalances, and the patient may have a normal QTC prolongation, normal QTCs. Do not rely on automatic interpretations of ECG. They will give you by a Bezet's formula. We have to calculate QTCs only by a Friedrichs formula and not by Bezet's formula. That is very important. So kindly take a note of that. Well, these are the dosages which we have already covered so far. And if the patient is not eligible for BPAL-M, the next shorter regimen and the new change in the regimen is 9 to 11 months of shorter oral MDR-TB regimen. What happened in this is the new is linezolid, where linezolid has been added over here instead of ichonyamide. Ichonyamide has been removed, linezolid has been added. We give only 2 months of linezolid along with bedaquiline, leoflox, clofazimine, pyrazinamide, ethambutol, and hydrocyanate. But there is a difference between the BPAL-M and shorter oral regimen. That is, if there is an extensive pulmonary disease, we cannot offer shorter BDQ-based regimen. We have to take the patient for longer BDQ-based regimen. Whereas if it is an extensive pulmonary disease, BPAL-M still can be given. So this is the change and the difference which we have to make a note of it. Coming to a small case, Dr. Nair sir, you can interrupt me if I am going beyond the time, no problem. Otherwise, I'll just wind up with this last case.
Yeah,
well,
think,
21 years old
short
female.
time, so probably you can finish with
Perfect.
this case.
Perfect. 21 years old female, married, staying and residing in UP, come to Mumbai for treatment, where cough with expectoration of more than a month, dyspnea, exertion grade 2 fever for more than 2 months, weight loss of more than, and appetite was lost. No family history of TB, no comorbidities present or seen. This was an X-ray chest where there was right side, upper zone, mid zone opacities. We all know, we all can see over here. Definitely seems to be a consolidation over here. Can be tubercular, can be pneumonia, can be anything. Check what we did. We sent a yes. We also sent a gene expert. We showed as MTB, which is positive detected, and rifampicin resistance was present and seen over here. We further saw what we got was LPA showing RIF resistance present. INHA resistance was present, showing only CAT mutation. INHA mutation was absent in this case. FQ resistance was present with the Gyri A3A mutation present. That means leoflox should not be given. High dose moxiflox can be given for our patient if required. But if you're thinking of BPAL-M, no need to stop or no need to replace moxiflox. Just continue moxiflox as it is. Second injectable mutation was seen on EIS mutation, which was present over here. This was the DST, which showed moxi 0.25 resistance and rifampicin as resistant, rest all the reverse sensitive. Well, this was a proven pre-XDR-TB case and was been enrolled under the program and was been offered a BPAL regimen only for 3 drugs: bedaquiline, pitomanid, and linezolid. Bedaquiline we gave for 400 milligram twice 2 weeks period, followed by 200 milligram alternate day of Monday, Wednesday, Friday for 26 weeks total. 200 milligram 26 weeks, 600 milligram 26 weeks. 4th week onward, we were surprised to see the cultures started coming negative. 4th week onwards. This is a really good thing, what we are seeing in BPAL-M. There are conversions like lesser to 4 weeks on an average for all our patients. 9-week culture negative, 13-week culture negative, 16-week culture for negative. This was an X-ray of 16th week, which showing as opacity is already reduced. There is a fibrosis which we can see, which has further, the lower limb. Now, since there is 20th week already, what we can do is we can reduce the dose from 600 milligram to 300 milligrams. And yes, that's what we did. We just reduced the dose and gave some gabapentinoids. We gave a pregabalin for 30 days and patient was symptomatically better. But then patient again came with complaint of severe increased peripheral neuropathy on 25th week of taking 300 milligram linezolid. And this was a period where only 1 week of duration was left for our regimen. So we just thought of withdrawing one single drug and give only bedaquiline pitomanid for next period of 1 week. That's it. Instead of shifting her to longer regimens. And yes, patient was doing good with gabapentins and duloxetine. We had stopped linezolid completely for just a 1 week period. The best part was 20th week was negative, 26th week was negative, and you can see the X-ray of 26 weeks and the follow-up X-ray post stopping of the treatment, that is post TB 6 months follow-up, which is showing hardly some opacity or just fibrosis over here on the right side. Well, by this, all our cultures were negative. Even 74th week of cultures turned out to be negative, and the X-ray was also good. I will just stop over here. Over to you. Thanks a lot, sir.
Thank you, Dr. Vikas. As usual, you've given an excellent talk covering all the areas. And I'm sure that the audience will have a lot of questions for you. I think questions are starting to come in. But before that, we have some other experts also with us, and we have a panel discussion which will go on for an hour or so. And after that, we'll take up the audience questions. So I think as your talk covered more of treatment, which you have made very clear, there have been a lot of audience questions coming with respect to treatment. But then the panel will focus more on, diagnosis and other aspects, and we'll come back to the treatment part with the audience questions. Before we start the panel discussion per se, can I request the team to project the CV slides of the other panelists so that I can introduce them before we actually move on to the panel. So thank you. We have first in the panel, Dr. Priti, who is also from Mumbai as Dr. Vikas. She is the professor and head of pulmonary medicine at JJ Hospital, Mumbai. Been fortunate to visit her hospital, and she has been a state level expert in the difficult treat clinic. She's in charge of pulmonary rehab and palliative care center, which has been started there. Her center actually is a national center of excellence. There are about 6 centers of excellence in various parts of India, and hers is one of them. She has been a PG teacher, eminent teacher, scholar, researcher, and Vikas, Dr. Priti, and myself, we're part of a team which actually could go all the way to Philippines and guide them in their drug-resistant TB program as well. The next panelist, we have Dr. Saroj Meena, who's a specialist at the National Institute of TB and Respiratory Diseases, one of the premier institutes for respiratory disease and tuberculosis in India, one of our national institutes for TB. At Delhi, she basically is in charge of the sleep center there, but her area of interest includes tuberculosis. And she has multiple publications in this area of tuberculosis. And she has also, got international experience in this area. So we look forward to hear from her. Next, we have Dr. Brijesh Koyani from Saurashtra, who's from Rajkot. And basically, he has fellowship in interventional pulmonology, is interested in tuberculosis, and also he has got several publications in this area. Welcoming Dr. Brijesh, and we eagerly wait to hear from you. And next we have Dr. Rishab from my side of the country, from the south of India, from Chennai. He is assistant professor in the Department of Respiratory Medicine in Savita Medical College, Chennai. And he also has various achievements in the area of respiratory medicine, and he is one of our upcoming young pulmonologists who has an interest in tuberculosis, and we will we'll hear from him in the panel. So thank you. We'll move on to the panel discussion per se. If you can start.
Before that, sir, I would like to introduce you also.
Sure.
Yes, Dr. Sanjeev Nair, sir, as you all know, very well-known person. No need of introduction. I'm very sure most of us know him as a name for itself. Dr. Sanjeev Nair, sir, who has been a chairman of zonal task force, and he was and he is a part of NTP guideline making program, a policymaker, one of the policymaker of India. Professor head of respiratory medicine of Government Medical College at Trivandrum, one of the member of National Technical Expert member, as well as the Global Technical Expert member at Philippines, where we are together. That is Dr. Priti ma'am, Sanjeev Nair sir, and myself. We three are the members of this GTech. And he is also the member of GBD, that is Chronic Respiratory Disease Group. And he has many articles on his name, that is around 92 articles, around more than 8 book chapters, and 35 H index, and plus 3 oration awards, which he have received all over. Well, he has also conducted many national and international trainings all over. And we are really grateful to have a person like you over here for moderating our session, and that too on a World TB Day, sir.
Thank you, Dr. Vikas. We'll move on with the panel. We can project the panelists here. Thank you. So we'll move on. We have a set of questions for the panelists, and we hope to cover the entire gamut of drug-sensitive and drug-resistant TB through this panel. There might be a bit because as usual, has given us a very good overview on the area. So there's some overlap between Dr. Vikas' talk and some of the panel questions, but of course, that is more of, revision and reiterating some of the important points. Of course, audience questions will also come back into those areas. So we'll come to the audience as well. So let us get going. So let me start with Dr. Priti. So let us start with a bit of basics. So Dr. Priti, can you please summarize for me in brief the diagnostic workup for a presumptive pulmonary TB patient who comes to us with the today's current guidelines?
Good evening, sir, and good evening, everybody. Thank you, the ICS, for allowing me to be a part of this webinar. Presumptive TB, what do we mean by that word presumptive TB? So presumptive TB is a person who's actually showing signs and symptoms and maybe also some X-ray findings of tuberculosis. So previously, a presumptive TB patient was defined by 4 symptoms. We had a 4-symptom complex where the patient either had cough, a complex of cough, fever, loss of appetite, and night sweats, which has been now expanded to a 10-symptom complex to have a, kind of a better perspective on tuberculosis diagnosis. So now, along with these 4-symptom complexes, we have also included symptoms like hemoptysis, loss of appetite, breathlessness, chest pain, and also, maybe organ-specific symptoms like if their patient has swelling or if the patient has got skeletal involvement, so maybe backache or, site-specific pain or CNS symptoms. So if we have a patient who is showing, who has symptoms of tuberculosis, what the NTP program says that mandatorily all patients have to be screened with the X-ray. So X-ray has now become a screening tool, a mandatory screening tool for all patients who have presumptive TB. Okay, so now we know that there is a symptom complex which now encompasses 10 symptoms. So if we have patients with symptoms of TB, we have to mandatorily get an X-ray. Beyond the X-ray, all patient samples all patients have to be microbiologically confirmed for tuberculosis. So we have to send samples. So if the patient has pulmonary tuberculosis or we are suspecting pulmonary tuberculosis, we have to send 2 sputum samples for gene expert. In case the patient is not able to produce sputum, then we can do induced sputum with 3% normal saline nebulization and send this induced sputum sample for examination. If that too is not possible, then, and if the patient is at a tertiary referral care center, we can refer the patient for bronchoscopy, take a bronchial washing or a bronchial alveolar lavage and send that sample for a gene expert. So the whole point is that we have to confirm the patient microbiologically for TB. If the patient has extrapulmonary symptoms or if the patient has extrapulmonary signs, so maybe if the patient has a swelling in the cervical region or the patient has a swelling in the axillary region, you think that's a lymph node, then a lymph node aspirate has to be sent both for a histopathology as well as a gene expert. If the patient has skeletal TB, suppose he has psoas abscess or he has a POTS find, then we have to aspirate that specimen as well and send for a gene expert. If the patient has CNS TB, then all the CSF has to be aspirated and sent for a gene expert. So the whole diagnosis is collecting a sample and sending to gene expert. That is how we would, go about diagnosing any form of both DS and DRT.
Thank you, Dr. Priti. So we'll move forward in interest of time. So Dr. Saroj, Meena, we had Dr. Priti elaborating a bit on the extrapulmonary diagnosis as well. But if you can carry that forward, so she has mentioned a bit of doing NAT in extrapulmonary TB, but if you can again elaborate a bit on presumptive extrapulmonary TB and what else we can do in addition to NAT.
It will already make my job much easy. I must say, KPTB, first of all, I would like to say thanks to ICS for having me here and giving me this opportunity to a disease panel, which is very close to my heart because not that I like this disease, but this is very close to my feel for it. So if coming to the EPTB has both diagnostic and therapeutic challenges when it comes to it. Dr. Priti has already mentioned much about it. And I must say that EPTB accounts for almost 15 to 20% of the total cases, TB cases in HI seronegative patient, and more than that in seropositive, around 40 to 50%. So it's a very important aspect of tuberculosis. And yes, we have to have a microbiological confirmation as per the symptom-wise, as per the system which is involved. Lymph node TB, pleural TB, cervical lymph node, followed by abdominal lymph node. They're the commonest form of extrapulmonary TB, followed by bone, joints, and spine tuberculosis. So yes, we should try each and every aspect to get a microbiological confirmation, get a sample, lymph node biopsy, or a sample from the site involved. But along with this, we do have to take care of the clinical aspect of the patient. So a detailed clinical history, a detailed clinical presentation of the patient is must before we proceed with the diagnosis. And we follow the same algorithm. We have to subject the sample to the CBNet. And if CBNet is positive, then first line LPA to look for additional resistance of INH. And then to midget culture. Each and every sample has to go midget culture. The only issue with the extrapulmonary TB, they are possivacillary. So midget may not grow, CBNet may come out to be negative. So we have to rely on clinical diagnosis. Second thing which we need to take into consideration in cases of APTB is the imaging modalities, which are much diagnostic in cases where we are failed to establish a diagnosis on the basis of bacteriological confirmation. So imaging modalities should be taken into consideration. They have classical feature. Histopathological examination of the site does tells us a lot about the disease process which is undergoing. And yes, clinical, in cases where we cannot prove microbiologically, though it is not recommended in the guidelines, but yes, we can take help of the tuberculin test because at least it helps in ruling out the negative. If it is negative, then we are sure we are not dealing with the tuberculosis, but then have to take into consideration the clinical scenario along with it. And DST is definitely not negotiable. So bacteriological confirmations, not test, molecular testing, LPA followed by another molecular testing, LPA is also, then a culture and imaging and clinical features. This is how together we can go ahead with the diagnosis of APTB and system-wise, yes.
Thank you. Thank you, Dr. Saroj. You covered the topic very well, both of you together. Before I move to the next panelist, I think one of the questions was related to, workup for extrapulmonary TB, which we have already covered. And there was another question, I think, by Dr. Bharat, which actually asked on whether a negative CBNAT can be considered sufficient to rule out TB. So if I can take that question myself, I'll come to the panelists later.
Definitely.
So basically,
Definitely.
both our panelists told you that NAT is the most important test to do, either for pulmonary TB or for extrapulmonary TB. But the sensitivity in NAT is not 100%. In pulmonary TB, if you take together, it is only around 75%. So, in smear positive pulmonary TB, it's almost 99%. But in smear negative pulmonary TB, it's almost something like 50%. So a significant percentage, about 25% of your TB, pulmonary TB, can be negative on NAT. So just having a NAT negative does not rule out TB. This becomes even more in extrapulmonary TB. That is what Dr. Saroj was telling you. So for example, if you take TB pleural effusion, which is bread and butter for pulmonologists, only about 17% of TB pleural effusions will be NAT positive. Remaining 83% will be negative on NAT. So when it comes to extrapulmonary TB, even higher proportion of TB patients will be negative on NAT, and there, you have to make diagnosis on other factors as well. So a negative NAT, the short answer is negative NAT does not rule out tuberculosis. So we'll move forward to the next question. Now, both Dr. Priti and Dr. Saroj actually mentioned on the necessity for sensitivity testing, but Dr. Brijesh, can you go forward and tell us what is this universal DST, which is part of the NTEP guidelines? What does it mean and how that is done?
Thank you, Sanjeev sir. Thank you, ICS, for providing me this platform. So now moving forward, what is universal DST and why it's important in the management of tuberculosis? Because universal drug sensitivity testing that the government in the NTP has upfronted. So today the management of tuberculosis is not just about the diagnostic TB and giving the treatment. It's about the diagnosis, the correct pattern of registration as well, even before you start the treatment. So DST is always an essence of the treatment of tuberculosis. So each and every diagnosed TB patient, whether it is a public or the private sector, must undergo the drug sensitivity testing at the baseline, at least for the rifampicin and isoniazid. So for the current NTP programmatic guidelines, all the patients who came TB positive should undergo the CBNAT or TrueNAT. If it come positive, if it come the rifampicin resistant, then further DST for the isoniazid and second line DST, LPA for FQ. So this DST is a transformational because first it can cause that it can make the shift from the empirical to the precise TB treatment. Earlier, we tend to start the treatment empirically or maybe with the sputum AFB and start the HRCT for 2 months and 4 months of HRE. Then at the end of treatment, maybe you come to know whether the patient is resistant to isoniazid as well. So this will prevent, universal DST will prevent the resistant tuberculosis, prevention of the amplified resistance. So if you start the incorrect first line TB treatment into the resistant TB, it will create the DRTB as well. With the universal DST, we can get the improved outcome as well. So early appropriate therapy will we can get the higher cure rates, as well as from the public health point of view, we can cut down the transmission as well. So identifying the resistant tuberculosis patient, we can reduce the community spread as well. So India has created this universal DST into the NTB program, and this coverage has steadily increased over the years across the public and the private sector, with integration of the CBNAT and the TrueNAT and the higher center SLP as well. So universal DST is not just a policy, but it's an extended standard of care. Still, we need the expansion of this universal DST with baseline INH resistance with early FQ DST as well. So we may increase the push towards the DST before treatment initiation whenever it's feasible. So yeah, the universal DST it has a cornerstone role in the management of tuberculosis.
Thank you, Dr. Brijesh. Before we move on to the next panel question, just again 2 more questions from the audience. So one question from Dr. Rajiv from Surat is on in CBNAT negative but clinically strong TB suspicion, how far should empiric treatment be pursued? So I mean that is related to what I told earlier. So I think a significant proportion of our TB patients may be negative on that, but then you have to make a clinical diagnosis. The term empiric treatment is no longer used in TB. So you actually make a diagnosis of clinically diagnosed TB and start the patient on treatment. And the other question was related to MDR-TB. So, the question was from Dr. Nishant on the fact that in a high MDR-TB prevalence setting, should empirical MDR treatment be started? I think the question was already answered just now, that empirical MDR treatment is not allowed. MDR is always a lab diagnosis, and you have to make a diagnosis of MDR through the universal DST and then make treatment on that. So we'll go forward to the next question. So the next question is to Dr. Rishab. So I think Dr. Vikas actually told us about the various tests. He had multiple slides on that. But could you, tell us in brief about the various NATs that we currently use in our country and the main advantage and disadvantage of each NAT?
Sure, sir. Thank you, first of all, and thank you, ICS, as well. It's a privilege and honor to be amongst this esteemed panel. So with regards to your question about NAT specifically, I'll start with what is NAT. So NAT is your nucleic acid amplification test. So it's there in the name, nucleic acid, which you amplify. So by definition, it would be a genotypic type of drug sensitivity testing. Broadly, I think I can categorize it into 3 main groups. The first would be mainly a cartridge-based nucleic acid amplification, or we can abbreviate it as CBNAT. Then you have your chip-based, which is an indigenous India-based product, which is your TrueNAT, and then broadly your molecular assays. So coming to what is available currently, it's predominantly your CBNAT, which detects both the mycobacteria as well as the presence or absence of rifampicin sensitivity. So that is through your RPO-B gene. The turnaround time is around 90 minutes to 2 hours on average. And the main disadvantage, I would say, is the setup cost, the laboratory air conditioning which is required, continuous power supply, and the relatively high technical expertise that is required to run the sample. To slightly improve on this, we have the TrueNAT, which is an indigenous, maybe India-specific product, which is highly useful in the grassroots level, in the peripheries, in the primary health centers, in the fields, outdoors. So the main advantage is battery operated. It can be portable. It's easily carried outside. However, a slight disadvantage, it takes a little longer to run the sample. It's a 2-step process. You first confirm the presence of mycobacteria. The second would be to run for rifampicin resistance or susceptibility. Third category, I would say, is your molecular assays or your line probe assays, which is also a PCR-based technology. The disadvantage with this is, apart from it being costly and technical expertise that is required to run the sample, unlike your CBNAT and your TrueNAT, it cannot be run on a smear negative sample. So you do require smear positive samples to run a line probe assay. If there is a smear negativity, you would maybe send it for culture or liquid culture, and the culture isolate can then be run for a line probe assay. So you have your first line LPA, which is predominantly isoniazid rifampicin. Then you have a second line LPA, which includes your fluoroquinolones and your second line injectables as well. Like Sir rightly mentioned in his talk, we do have expert XDR for an extended spectrum of CVNAT. It's currently not yet available in the program, but maybe down the line, along with next-gen sequencing, we have more options for drug sensitivity testing.
Thank you. Thank you, Rishab, for telling that in short as well, covering a very vast topic in a very short period. Thank you for that. So we'll move forward. I think some of the audience questions that are coming up, probably I'll be covering in the questions to the panel. So we'll keep them pending. If towards the end of our panel discussion, we'll come back to the audience questions. Now, Dr. Vikas, so, one of the questions, as I read out earlier, was related to high prevalent areas. Generally, for MDR-TB, it's considered a hotspot when primary MDR is more than 6%, which we don't have in India. So our primary MDR rates are less than 3%. So we definitely, our country doesn't come in a high MDR area, but there are areas in India where actually MDR rates are actually high. So it's quite a variable situation. So certain parts of the country have very high resistance levels, whereas certain other parts of the country have lower resistance level. So in fact, in my part of the country, it's only 1% of the new cases which actually have MDR-TB, whereas you come from an area where I believe that the percentage is substantially much more than that. So what do you believe in terms of, what are the reasons why there is such a high variability and why it is so high in certain parts of the country? You are the right person.
Definitely. Yeah, so because I am coming from a place where we can see more than 45% of primary resistance. Now, that's a fact. This very shocking figure, where patient never been exposed to TB in past, but still having primary tuberculosis. If you do a gene expert showing resistance, which is not as equal as in your area, I'm very sure that you might not be seeing a primary resistance as high as 45%. Well, we need to understand something over here. How the disease is transmitted. First is whether it is primary or acquired. Let us categorize two things. So if it is primary, like for example, a strain, resistant strain, giving directly a resistant strain to a community where there is overpopulation. So there is a community spread which is going on in a densely populated area. So there are many hotspots or clusters in some of the areas in Mumbai also where you can see such high primary DRTB resistance. So this explains somewhere a geographical pockets with a high DRTB. In your area, it's not there. In our area, it's there. In some of our area where there are a lot of migratory population coming over here, where they come from some other states, other cities, they come over here maybe for treatment, they come over here maybe for work, for occupation, they're daily wages workers who come over here because Mumbai being a hub for, commercial hub. So many of these people, they come from village over here to work on daily basis. So it's not necessary that they're going to be over here for good 24 months of period or 18 months of period. Sometimes they just come over here, they manage to get diagnosed, they take some treatment, they drop it in between and they go to their native or their village places. There is a default in the regimen. So there is somewhere the failure implementation on our part, where we have to actually counsel patient thoroughly. We have to keep a track of the patient right from start till the end. So we have to take each and every possible measures to retain this patient under the program, and that's what NTP is doing. I know the health visitors and the health workers in the field who are working day in, day out for their enrolled patients. So number of XYZ patient enrolled in their category, they see to it that they actually take care of the patients. But still in this slum of India, in slum of Mumbai, this is a very common practice. What we are seeing, that when the patient comes over here and then go to his native places, they just stop treatment, they're defaulters, and this is a problem over here. Then comes the socio-economic status of the patient. So not necessarily each and every state have equal socio-economic status. Some of them have a low socio-economic status where the daily intake, the food intake is less on the lower side. And as we all know, second line drugs also have an equal and more side effects where they also need a good nutrition. Not only medication, but also nutrition is a very important part of the treatment regimen over here. And as these patients, some of these patients who are belonging from this low socioeconomic status patient, they don't have a proper food intake, and that is also one of the part of failing of or more number of resistance what we can see in their areas. Most important is drug supply. Our program needs to have a regular uninterrupted drug supply each and everywhere. Now we see that under the program there were shortage of the pills, shortage of the drugs, but it is not because the program is not doing good. No, it is a local procurement, it is a local issue, local implementation failure over there. So local authorities have to upfront tell the center committees that this is our intent, this is our need, this is our need of the drugs, and accordingly kindly arrange for the drugs priorly than waiting or for the at the end moment, ordering at the end moment. Logistic always a challenge. Managing the drugs at the end moment is always being a challenge. So these are some of the points where we can see provision of availability of the drugs. Say delaminide is very much swiftly available in my area. Maybe it won't be available as swiftly as in your area. So the regimen which you provide over there, where the drug replacement is required, delaminide is required along with bedaquiline, the regimen may become weaker if the delaminide is unavailable over there in your area. So these are some of the points where, and plus the clinicians and the private practice. Private and public should have a good coordination for the practice. Is a very, very and very important thing. Only private sectors cannot take care or treat our patients thoroughly, because these drugs, newer drugs, are not available in the private market. It is only available along with the program, under the program. So each and every drug should have a good combination of a regimen as per the DST, as per the mutation, should be studied thoroughly, and the regimen should be made. If the regimen is not made appropriately, only 2 or 3 drugs will not take care of the drug resistance. Rather, we will end up augmenting the resistance. So that is also another point which need to be taken care of.
Thank you. Thank you, Dr. Vikas. You covered a lot of points. So again, I'll take you back to Dr. Vikas' first slide. He always starts his presentation with that slide, and a very clear message is given to all of us that the private sector on its own or the government sector on its own cannot actually do good, and everybody has to work together. In fact, I love the presentation made by the IMA national president, Dr. R.V. Ashokan, who was a past president. His slide would always start with the Indian flag, and he would say, this is the national flag of India. It is not the government flag, it is not the private flag, it belongs to all Indians. So similarly, TB program also belongs to everyone, not just the private or the government, it's for everybody. And just one point, I would like to highlight. In many parts of India where resistance is high, when you talk to the doctors there, they would actually end up blaming patients. So something that we started in 1998, when we started the revised national program in India, TB program in India, RNDCP in India, was the fact that we made it very clear that whatever goes wrong with the patient, we will never blame the patient. So whatever is there with the patient has to be done by the health system, maybe the doctors, maybe the health workers, maybe the administrators. But at the end of the day, it is actually our job. So, that part of it has to be taken care of. Dr. Vikas, Dr. Priti, myself, we have been to various parts of the world, and we have spoken to doctors and patients in various parts of the world. Wherever you go, this problem of patients is the same. It's not a unique problem for, my city or your city. Wherever you go, you patients will not take treatment. Nobody likes to take treatment for such a long period. If you and I take treatment also, that will be the same thing. So it's not very easy to take treatment. These are toxic drugs. Social stigma is there. So many issues are there. That is common all over the world. So it is our job to, overcome all that and ensure that our patients take treatment. So I think
just because we don't have access to the newer drugs like Pitamanid, we do not refer the patient to the government sector is wrong. Logically, we should counsel the patient and we should direct him to the government sector so that he gets an access to the newer drugs like Bipal and regimen, which is available only in public sector.
What Dr. Vikas is saying is, I know certain parts of India where, people would not refer. Dr. Vikas is the brightest example of working government and private working together. But I know places in India, I will not name places, where people are not referred to the government. So because they don't have any access to bedaquiline, delaminide, or any of the new drugs, those places, still patients are on kanamycin injection for 6 months and all, which is actually criminal. WHO has taken out those drugs from the drug list because they are so toxic drugs. But just because you don't want to let go of your patient and send the patient to the government, wherever the drug, you don't have to send the patient. In fact, the drugs can come to you. That's a different issue. We'll discuss that later. But that is the scenario. We'll move on. We're running out of time, so we'll move on. We'll come back to Dr. Priti again. So Dr. Priti, when I introduced her, I said that she not only leads a department of respiratory medicine, she also leads a national center of excellence, and she put in a lot of hard work for her hospital to be designated as a center of excellence. So what I want to hear from Dr. Priti is, we were discussing treatment, diagnosis and treatment in terms of technology, in terms of drugs and all that. But the program is now moving even further from that, from DRTB. It's moving forward, and your center of excellence has so many components. Can you just, tell all of us what are the other components which the center of excellence has, and what are those new areas where other centers can also aspire to, do in TB?
So beyond diagnosis and treatment, we also cater to other aspects of the patient. So one of them is rehabilitations, and so most of the times we think that rehabilitation has to be undertaken when the patient is really becoming sick. But at our center, we have a rehabilitation center which has a physiotherapist, a nutritionist, and a counselor. So our rehabilitation for our TB patient begins right at diagnosis, where the psychiatrist, the psychologist actually evaluates the patient, gives a counseling for 30-35 minutes, and sees also counsels about adherence to treatment and follow-up during ADR. So we are trying right from the beginning to see that the patient is adherent to treatment and is following up regularly. We also have a dietitian who actually looks at the diet of the patient. So we are in Mumbai, we have patients from different parts of the country following different dietary patterns. So she looks at the diet of the patients, calculates the calories, calculates the protein requirements, and actually prescribes a diet, a diet chart to the patient, and tries to be as local as possible and tries to be as patient-centric as possible. We also have a physiotherapist. So most of our MDR TB patients or our TB patients, most of them have cough. They have difficulty in getting out the sputum. They are breathless. So our physiotherapy starts with basic things, like chest clearance exercises, dyspnea relieving postures, helping them with the upper and the lower muscle strength. So this is the kind of rehab part, which is a very important component of patient treatment along with the medicines as well. So we've seen that the patients really improve well. In fact, we have now patients who, like TB champions, or patients who've gotten better, trying to educate other patients who have just been diagnosed with TB. Then we also are in tie-up with a palliative care center in Mumbai, that is Sukun Niraya. So we have patients whom we really there have been multiple questions I was seeing in the chat box. So, we have no treatment options left for the patients. So what do we do to these patients? So we send them to a palliative care center. So we have both a rehab and a palliative care center. Palliative care attachment. So this goes beyond just TB drugs and TB diagnostics. Also, we are a medical college with the cardiovascular thoracic surgery department. So along with the drugs, we also offer surgical options to these patients. So if we have patients who are with MDR TB coming with recurrent TB and a localized disease, we also refer these patients to the CVTS department for surgical options. And even patients with extensive TB, sometimes if our CVTS agrees to do, we do surgeries even in a sputum positive patient. So surgical aspects, also NTM treatment. So what drugs we have available in the system is mostly for MTB, not so, like Dr. Vikas has spoken about the guidelines, it's mostly for MTB, MDR TB, DSTB, DRTB. But for NTM, we're getting a lot of NTMs. So the program does provide medications for patients who have been diagnosed with NTM infection. So it's just not DRTB, but going beyond that. So this is what our center does. So, and I think most of the other COEs and most of the other TB centers have been doing. In fact, across Maharashtra, I'm a part of something called as Maharashtra State TB Association. So Maharashtra State TB Association actually is in the forefront of implementing rehabilitative care centers, pulmonary rehab centers across Maharashtra, and has opened multiple centers and has supported multiple centers across Maharashtra for PRCs for TB. One is in Kandivali in Mumbai, but across other districts of Maharashtra also they have supported. So, it's not only the drugs, but also the other aspects.
Thank you. Thank you, Dr. Priti. I think Dr. Priti also has a national center of excellence for pediatric TB in our hospital. So that is also there. In fact, one of the big earliest signs that you can see whether you're doing well with respect to TB in your state is that you will stop seeing children with TB. So we are facing that scenario in Kerala, where our pediatricians are no longer seeing that much of TB. And in fact, one area where I get stuck is pediatric MDR TB, where, I've not seen a case for years now. So that is the kind of scenario we have. And when I visited Dr. Preeti's center, I could see a lot of children with the MDR-TB being given very good care. It's a challenge. In fact, one of the questions, the audience questions was on that, but we'll come to that later. Thank you, Dr. Preeti. We'll move on to the next question. So on one hand, we have Dr. Preeti, who's coming from a so-called National Center of Excellence, which is a new concept, which was not there earlier, but it's a new concept. And the government has set up certain criteria that A, B, C, D, E, there's a checklist. And then based on that, if all those things are there, it would be designation as a National Center of Excellence, and they would be promoted to even excel further. On the other hand, we have certain national institutes also. So some of the things that, like, for example, whole genome sequencing that Dr. Vikas was mentioning earlier, it is present in some of these national institutes. The reason for that is totally different. It's an epidemiological tool rather than a diagnostic tool. Some of the latest technologies, assessment of new technologies, so many new technologies are coming in TB. So the new technologies are being, as all this happened in a national institute. And we are fortunate that Dr. Saroj, who's there with us, works in a national institute, which is a premier National Institute for TB and respiratory diseases. So Dr. Saroj, can you just tell us what all services your institution offers so that, we are all aware on what a national level institute can actually offer to TB patients?
Thank you, sir, for the question. And I'll take lots of pride in answering this question. So, National Institute of TB and NITRD known as, we are serving TB patients since 1956 till date with gradual advancement in diagnostic and adapting to the new diagnostic policies and all. So we are National Center of Excellence in adult TB care and pediatric TB care both. And we do have a National Center of Excellence in TB HIV care also. And we have a WHO endorsed microbiology lab. So if I'll divide this case into, like, we have a diagnostic centers where we provide we are National Reference Laboratory and a NABL accredited laboratory, microbiology laboratory. We also have total drug monitoring thing, which is, I think, the second government institute in the country which is doing therapeutic drug monitoring. And we are, I'm so proud to say that we are doing both for the first line and the second line drug also, and it is totally quality controlled. And that is helping a lot of our patients. We also have a world-class intervention pulmonology section, which helps us to make diagnosis in cases of APTB patient where we fail to get a microbiological confirmation to the conventional sputum microscopy or sputum CPNet sample. So we have that, and that have EVAs, radial EVAs, CARM, and all the facilities. And adding to the diagnostic part and the therapeutic part, we are coming up with a cath lab, which will be providing the facility for bronchial artery embolization. So that is a new vision. Maybe within a year's time, NITR will be start doing BAE at home itself. So these are the things. We do have a thoracic surgery department, which is dedicated to all the TB patients, positive, post-TB sequelae, and other, obviously, non-TB chest diseases also. Another feature which I would like to add, we have a negative suction MDR wards, which are dedicated to MDR TB patient, saying that I'm not promoting negative suction MDR wards. If your wards are well ventilated, they have a good air exchange, then that is also good enough. But yeah, we do have negative suction MDR wards. And add on to that, NITRD does have a critical care unit for TB patients. So, and recently, past 1 year, we have developed an MDR TB ICU, which has a negative suction. The negative suction prevents the medical staff who is working there. Actually, that is the basic behind TB patient, because they're intubated and a lot of airborne infection is there. Along with that, we do intubate this patient. From 2013, we are intubating TB patient. And I must say, we are not able to save 100% of these patients, but we have saved at least 30 to 40% of these patients through our critical care unit. Another thing in the wards, if I come across, we have non-invasive BiPAP machines. Those patients who come in type 1 or type 2 respiratory failure, so we have 100 plus BiPAP machines. So this is the thing about the TB. And apart from this, like Dr. Priti Center is having, we have a rehab and yoga center. And our yoga center people, they go to every ward twice in a week, give demonstration of the breathing exercises to all our patients who are admitted under us. That helps the post-TB sequelae patients also. That helps the TB patients also. Nutrition, yes, we have a separate nutrition section. So I must say in under one umbrella, we are having everything for a TB patient and a non-TB patient at NITRD.
Yeah, so I think you have covered the entire gamut. In addition, I think I should appreciate that it is a center, national center for training also. So many of us have gone there for training. I've gone as a trainer and a trainee in to the institution. They run a national difficult to treat clinic in which I've been participant. Many of us have been participating, which is again excellent. And very friendly doctors, including Dr. Saroj, all of them. You can always reach out to them if you're in Delhi. Please pay a visit. You know, it's just next to Qutub Minar, so you can have a look at Qutub Minar, walk into NITRD, meet all these brilliant, friendly doctors, and have a look around. It's a beautiful institution. So we'll move on in interest of time.
NITRD does have a role in research. At one point of time, we have more than 40 research projects going on in TB and non-TB area.
So, many important publications as well. Yeah.
Yes.
So we'll move forward. So I was just bringing in because I knew there were some young people in the audience. So just highlighting. So in fact, like what Dr. Saroj said, you know, the negatively ventilated ward, that is the only one we have in the country in terms of, you know, technology demonstration. Not that that is needed for, I mean, every institution. We have done it to show to the world that India can also do it. But, you know, on the other extreme, my ward in Trivandrum is so well ventilated that the air exchanges are somewhere around 60, you know, so you need only 12, but we have 60 and, you know, it's safer than many of the other wards. So that way it goes. Anyway, we'll move forward. So I'll move to Dr. Brijesh. So, you know, a lot of questions from the audience are coming, Dr. Brijesh. I'm not going to read every one of them, but they are talking in terms of what if, you know, NAT is showing rifampicin resistance and LPA is not showing resistance. What if this test is negative, or what would be the other test? So based on what discussion we had so far on the various, you know, rapid test, DST tests and all that, what do you feel are the main advantages and disadvantages of these rapid tests?
Thank you, Dr. Sanjeev. So I think Dr. Rishab has already mentioned that what are these various techniques of rapid DST platforms. So I think as a clinician, as a pulmonologist, the rapid DST platform, especially the CBNAT, it is a single most impactful diagnostic test in the TB care. So the key advantage of the CBNAT gene expert is that it is the speed. The results are available within 30 minutes to 2 hours. So same day diagnosis and the treatment initiation. The second one is we can readily diagnose the rifampicin resistance, which is as a surrogate marker to diagnose the MDR-TB. The ease of interpretation, and anybody can, any clinician, any practitioner can interpret the result, and the high sensitivity in the even in the smear negative tuberculosis pulmonary TB, and perform programmatic acceptance. So while with coming universal DST, the CBNAT, we can offer each and every patient of the pulmonary tuberculosis. But the key disadvantage is that it has a limited information, so you can only idea have of only rifampicin resistance. So it cannot detect the isoniazid or FQ or any other drug resistance. Although rare, but yes, false positive rifampicin resistance, it can also be clinically significant sometimes, and it cannot monitor the treatment response. So yes, this is the few limitations of the CBNAT. If we talk about the TrueNAT, it's a game changer because it's readily available. It's even it can give the result even as compared to the CBNAT. TrueNAT can give the result within 30 minutes. So yeah, it's point of care capability. It's a portable, and because CBNAT is a cartridge based, it is a cheap base, so it can be placed in the peripheral hospital, rural or anywhere, or any medical colleges. The other that less infrastructure is required for the TrueNAT, but the disadvantages are even the same as the sputum CBNAT. like it has a limitation. It can only diagnose the rifampicin resistance. Not ideal for very high volume centers. If you talk about the LPA, so yes, LPA is a most clinically informative rapid DST tool. So the advantage is extended resistance detection. So it can detect the rifampicin resistance, isoniazid resistance. Second line LPA, you can diagnose the fluoroquinolone and other drugs resistance as well. So it can guide the treatment regimen. You can sometimes individualize the treatment based on the LPA results, and as compared to the culture, it can give the result faster. But the key disadvantage is that the first one is that you need the smear positive sample or a culture isolate to diagnose it. So, and it need highly skilled technician and the person to operate the LPA device. So these are the few advantages and disadvantages of these rapid DST testings.
Thank you. So you covered the area. It's a lot to say, but I know you've stopped in interest of time. So we'll move forward. So, Dr. Brijesh actually told us about the rapid molecular tests. So those are the go-to tests now in terms of, popularity, in terms of being promoted by the program. But then the traditional tests in terms of the culture, which are called the phenotypic tests, are also there, and they also have their relevance. So, can Dr. Rishab, can you please compare these, genotypic tests with the phenotypic tests, and in this era of molecular testing, what would be the advantage of one over the other?
Thank you, sir. Like Dr. Brijesh rightly said, I think I'll start my explanation from the DST and the rapid DST that we are doing as part of the program. So that would come under genotypic testing. And one of the main advantages, like he said, is the fact that you get same day, sometimes even same hour results. So immediately you find out whether the patient has TB, is it Mycobacterium tuberculosis, is the patient sensitive to rifampicin, and you immediately triage and categorize the patient into a DSTB or a DRTB algorithm. So that is essential. But fundamentally, the issue with DSTB, rapid DSTB testing is because we can only test for a particular gene or a particular mutation which confers resistance, we can only test for what we know. And what I mean by that is, we know that, let's say, RPOB gene confers rifampicin resistance. There are other modalities of conferring resistance for the mycobacteria. There might be other genes that we have not yet discovered that confer resistance to different drugs. So not necessarily a CBNAT, for example, a negative result need not rule out tuberculosis. And same way, there might, even if a patient shows sensitivity to a particular drug on genotypic testing, it need not translate to phenotypic testing. Phenotypic testing, what is specifically culture. So that is very similar to your bacterial culture in a sense that the mycobacteria has grown in a medium in the presence of anti-tubercular drugs, and the inhibition of growth is monitored and checked. The main disadvantage is a slightly longer duration. By slightly longer, I mean from 2 weeks to up to 8 weeks, depending on whether it's a liquid or a solid culture medium. But the absolute gold standard would still be phenotypic testing. For the reasons I previously mentioned, the fact that phenotypic testing and genotypic testing don't always correlate 1:1. Even if a patient is resistant or has a resistant gene, it need not have a functional limitation to the regimen per se. This we can see even in the BPAL-M regimen, where irrespective of fluoroquinolone resistance detected on DST, patient is still given the BPAL-M regimen. Moxifloxacin is not compromised. So both have a place in the algorithm. The rapid DST or the genotypic testing would be done upfront, where we immediately find out the presence of mycobacterium resistance, triage the patient into DSTB or DRTB. While your phenotypic testing would be a backup and would give you the definitive diagnosis, and if required, it allows you to modify the regimen. Secondly, because we spoke about BPAL-M, currently the only way we can test for the second line and the newer drugs, the dilaminates, the pretominids, the linazolids, the bedaquilins, is only through phenotypic testing at the moment. So there definitely is a role for both in the current NTAP guidelines.
Thank you. That was well presented, Dr. Rishab. So he rightly pointed out why, despite having molecular tests, there are certain reasons for doing phenotypic testing. Also point out the advantage and disadvantage of both one area which is now internationally, I mean, not now, for some time being internationally debated at length, is that what is the gold standard? So for long we believed that phenotypic testing is the gold standard, but now many people are challenging that on whether it's time to even challenge the gold standard. Anyway, that is something for the future. Let the microbiologists come out with their final verdict on that. So we'll move further. So basically, we were hoping that we will. We have a lot of questions for the panel, and we are hoping that by 10 o'clock we'll cover all those questions. But then a lot of interesting discussion, and the discussion is getting too long. So probably with this last question to the panel, I'll stop the panel questions and then I'll move to the audience questions, because a lot of audience questions are coming. We will finish sharp before 10:30. Before I close, I'll need final comments from my panel as well. So maybe we will not be able to cover all the questions. So many questions coming in. I thank audience for turning up in big numbers. I'm told that around 2,000 people joined our session for today, and also for bringing in so many interesting questions. I apologize that time doesn't permit you to take all your questions, but we'll rush through them after this last question that I'll be asking Dr. Vikas. So, Dr. Vikas, you in your talk you had mentioned about increasing resistance, particularly in your part of the country. And we were so happy to get this new drug, bedaquiline. And, with the advent of bedaquiline, until then, the country had a success rate of 44-48% treatment success for MDR-TB. You used to feel sorry for the patients that despite taking treatment for 2 years, 3 years and all, only around 45%, 48% are getting cured. Of course, my state had a higher success rate, but even that was at 66%. So it never went above 65 and all that, even in some of the better areas. But then suddenly these new drugs came in, bedaquiline came in, delamanid came in, and regimes became shorter. And now the success rates are in the range of 75%. I mean, the days when I was doing PG, if I had gone for my MD examination, and I had said that I will get a 75% success for MDR-TB, they would have failed me in my exam. So that is the kind of remarkable difference that these new drugs, bedaquiline and all, have made. But now, sadly, I hear from you that a significant percentage of patients in your area are also getting resistant to bedaquiline. That is very worrying for people like me who have worked in the program for the last 30 years or so. So how can we protect these new drugs? I mean, we are getting new drugs, bedaquiline, delamanid, preterminate, citozolid is on its way. So many other drugs are also coming. But if the rapidity with which the resistance occurs to these drugs, outpaces the rapidity with which new drugs come in, then we are in for big trouble. So can you tell us how we can save these drugs?
Yeah. So right now what we are seeing is there is a primary resistance of many of these drugs also. So that means there is an ongoing community transmission which is going on, especially because of the overpopulation in the slums. So these slums, until and unless we intervene in the slums, which are over-occupied, which are densely populated, tackling or bringing up or coming up with any new drug, whatever new drug, however good the regimen is, we won't be able to achieve the target of getting down the incidence as compared to 2015, what the target was. Because in these slum areas, what we see is in a 150 square feet area, they are managing 7 to 8 members are managing to live in that area of 150 square feet. Now just imagine a 150 square feet area and 8 people living in that small room with only one single entry and exit door, no window, no cross ventilation at all. So what is the dwelling in where they're living? They're managing to live over here. And this is not only in this area. It is true for each and every slums all over, I would say, everywhere in India, not only in Mumbai. But yes, because Mumbai being, again, I repeat the same thing, because Mumbai is one of the commercial hub place where people are coming over here to earn money, to earn their bread and butter on daily wages. Daily wages workers are over here. There are many people who come over here from outside over here. So these people, they just take their medications for certain days, certain period, and they just happen to default their treatment regimen. So somewhere we will have to become more strict in this switch over of these migratory populations, especially when they come over here and when they come and they leave back to their states or the cities or maybe their villages. There will have to be a bit more stringent steps will have to be taken over here. Secondly, availability of this newer drug like bedaquiline specifically, which is there in the open market right now. Recently, what we have seen is the company has come up with who is selling bedaquiline. He is least bothered to check for the resistance status. He is least bothered to check for the gene expert or the report or other DST, and they are just providing the drug to the to any XYZ person. You just call up the person, and the 18 months or 6 months bedaquiline will be handed over to the patient relative. Well, I would say such practice should not be encouraged, because each and every physician cannot treat DRTB. There are certain do's and don'ts. There are certain there are certain norms which you need to follow it very strictly. Regimen making should be really good. We cannot just provide bedaquiline just because it has not been exposed in past and give some of the drugs which are showing sensitive as per the DST. No, there is something called as drugogram, drug history, family history, a close contact of DRTB. Each and every factor need to be taken into consideration, whether the patient is able to purchase the medications in the private sector for good 18 months of period. He should be well informed before starting the treatment in the private sector. So all these things we will have to inform the patient before prescribing or starting our pen to write down the newer drugs along with the other second line drugs for our private physicians, private patients. That's very important, because the more and more you write these newer drugs along with just the drugs which are sensitive on the DST, and you make a regimen which is not up to the mark, we are going to see a lot of resistance in the field. And this is not going to happen only in Mumbai, but everywhere, wherever you go, you will be able to see the similar sort of picture for sure.
Thank you, Dr. Vikas. It is going to be a challenge for us, So if we lose these new drugs also, then we have nothing left for our patients and nothing left to hand over to the new generation. So I think with that, I will stop the panel discussion for now, and we'll move to the audience questions. I would request the panelists to maybe take up questions as per your wish or priority, or maybe I can ask any of you to. So the first question that came in was from Dr. Mansi, and she was asking that if a patient had received DSTB treatment in the past, more than 10 years back, and now again comes with DSTB, what would be the regime for such a patient? So can I go with Dr. Brijesh? Or anybody, I mean, whoever is comfortable. Brijesh muted. Yeah, you can take it to Vikas.
Okay. So any patient given or treated as DSTB in past, and if he's coming up as the new fresh case again, for example, if he's recently treated just before 2 years, and if you do a gene expert showing as MTB detected medium or low and resistance not detected, trust me, you do not rely on this report. The message to be taken over here is recently treated cases, maybe within a period of 2 years, gene experts still will come positive. Do not over-treat your patient by giving again first-line drugs, or rather even second-line drugs. You don't need to give second-line drugs for sure, because your gene expert is still showing rifampicin resistance not detected. But check for the history of the patient, whether is it treated just 2 years or more than 2 years. If it is more than 2 years, still you can treat your patient with first-line drugs only. No need to give any second-line drugs. See to it, you trace first-line LPA report over here to see the sensitivity of INH. INH should also be sensitive over here. Resistance should be absent for INH CAG, and INH mutation should be absent. That means H and R both should be sensitive, and you don't need any quinolone or any second-line drugs or any bedaquiline. Just treat with mere FDCs once you confirm it is reinfection or relapse of the patient.
Thank you, Dr. Vikas. So, Dr. Mansi, to your question, patient treated more than 10 years back for DSTB comes again now and is found to have DSTB, you give the same regimen. There is no confusion on that. The same DSTB regimen is given. Like Dr. Vikas told us, you will also further, all patients, not just this patient, even a new patient gets evaluated with a first-line LPA for INH resistance. So if there is INH resistance, there's a different regime for that. The gene expert showing rifampicin resistance not detected means there will be no rifampicin resistance, even though we will be evaluating the patient further. So I think that is a short answer to that. The next question is, in the same scenario somebody has asked, Dr. Prasad has asked, if it's a previously treated patient, which test should be prioritized? Would you do LPA, culture, or, gene expert? If I can ask the question to Dr. Saroj,
Yes,
a
sir.
previously treated
So,
patient coming in, which is a test
whether
to
it's a previously,
prioritize.
yeah, so whether it's a previously treated cases or it's a new case, we will follow the same regimen with the clinical features of TB patient presenting. We will first expose the CBNet. Reason behind it, we get the report of CBNet little early as compared to the LP and the MISIT reports. So once we have a CBNet report which is detecting, which tells us about the load of the bacteria, also high, medium, low, and a sensitive pattern to rifampicin or resistance pattern, we can go ahead with the regimen. So it's the CBNet followed by LPA. And yes, each and every patient has to undergo culture, MISIT. Solid if
Thank you.
possible, that is ideal, but yeah.
I think, yeah, you're given a very crisp and short answer, which is as per the program. I'll just balance between what Dr. Vikas said and what Dr. Saroj said. So what Dr. Vikas was mentioning is a very peculiar situation. Suppose the patient is cured today. So how much difference is there between the cure and the recurrence of TB? So that is related to the diagnosis of TB. Like with respect to resistance, if the resistance has come as not detected, that is fine. With the diagnosis of TB, say if the patient was cured 10 years back in a peripheral institution, now comes to your institution, and then if you do a NAT and the NAT is MTB detected, could be dead bacteria as well. So in that scenario, to maybe know that this is TB, you might consider doing a culture, but like Dr. Saroj said, the algorithm remains the same. So we'll move forward. Next question was, I think it's more of a theoretical question. So, after completing a full course of therapy for 1 year, patient has, Dr. Saket was asking, so patient had a recurrence of TB within 1 year. So how would you find out whether it is relapse or reinfection? And does it actually change your management approach? Dr. Priti, you want to take this?
So it is relapse or reinfection. Again, we would have to, as I said, as Madam had said, that you have to follow the algorithm and definitely send for a culture, see if the culture is positive, and then run tests on the culture and then decide about treating the patient. So we have the 2-year gap where the patient can still come gene export positive, but then cultures would be very vital to decide about the treatment of this patient.
Thank you. So I think again a sweet short answer. So what Dr. Priti is saying that at the end of the day, your later part of the question, Dr. Saket, was, does it make a difference? No, it doesn't make a difference. So you will evaluate the patient. Patient has DSTB, you'll treat DSTB. DRTB, you'll treat DRTB. From a theoretical point of view, if you want to know between reinfection and reactivation, technology is there. The technology is available in some of our national institutes where, spoligotyping is done, RFLP is done, even your whole genome sequencing machine. 5 machines that the government owns, which sit in the institutions, look for transmission chain analysis. So, find out who infected who. So that is theoretically possible, but, we are with 27 lakh cases every year in India. It is not really possible for us with even, hundreds or thousands of machines like this to find out who infected who. There are countries which do that because their numbers are low. So I think we'll move forward with that. The next question was, Vikas, I'll give this to you. A patient on bedaquiline develops QT segment prolongation. How do you decide whether to continue the regime, interrupt the regime, or replace the drug, especially when the options are limited?
Yeah. So the moment QTC prolongation is seen, first thing, think of 3 drugs: bedaquiline, moxiflox.
Yeah, probably because you can also say at what level of QT prolongation you do this.
Yeah. So for male, as I already showed in my presentation, for male and for female, for male it is more than 450, for female it is more than 470. So if you see as high as 450, more than 450 or more than 470 in case of female, but if it is calculated only with Federer formula, let me be very clear over here, not with Bejer's formula. Do not take the direct interpreted report of ECG. It always calculated with Bejer's formula. The auto calculation, you need to calculate as per the formula for the Fredericia formula, and then also if it is more than 415 males and more than 417 females, repeat ECG, reconfirm is it really high. Yes, if it is high, then consider the drugs, that is bedaquiline, moxiflox high dose, and clofazimine. These are the 3 drugs which causes QTC prolongations. Immediately send a serum electrolyte for the patient, because many times serum electrolytes can also lead to this sudden problem. If the electrolytes are imbalanced, rectify them, again the QTCs will come back to normal. So the moment your QTCs are prolonged, you have to hold these QTC prolonging drugs for a period of time. Repeat ECG after 24 hours. If now it has come down, then the time comes to reintroduce one single drug at a time, and the order being first bedaquiline, then maybe moxifloxacin, and then maybe clofazimine in a period of 3 days, followed by ECG at every third day if required. So also check for any other drugs being added to the patient. For example, drugs like antifungal drugs or say antimalarial drugs, or maybe a drug commonest like ondansetron, which we give for our patient who is frequently vomiting. All these drugs causes QTC prolongation. So if by any chance these drugs are being added, just hold those drugs and then repeat a ECG after 24 hours, check for the QTCs, still on the higher side, hold the three drugs which are responsible for QTC prolongation, and within 3 days, introduce one single at a time, repeating ECGs, and then you can come back to a normal regimen.
Thank you. Thank you. So we had the question from Dr. Vijay. So Dr. Vijay, Dr. Vikas can even tell this in his sleep, So, but many of us cannot remember a lot of this. So, what I tell my PGs, and when I go to trainings, what I say is that a PDF of the book, the guideline document that Dr. Vikas showed, is available on the NTEP website. Please download that and keep it in your book, your phone. So, the moment QTC goes up, your question was, when do we stop? When do we interrupt? When do we replace the drug? So you have various levels at which you can continue and do the things that Vikas told you just now on testing electrolytes. There are certain levels of QTC at which you have to stop the drug and do the evaluation. And there are certain levels of QTC where you decide that I will not start the drug anymore. So at that level, you will have to go for replacement, as you asked in your question. At the other levels, you stop the drug, and there is a table, a flow chart in the book, which will tell you at what point you restart the drug, which drug to start first, when to start the next drug, and all that. So it's always you follow the guideline. So even it's not just for us, the pulmonologist. Even when my consultation goes to the nephrologist, what I do is my man who takes the patient to the nephrologist takes the consultation with the photostat of the page in the guideline document, which tells that at this, EGFR, you have to reduce the dose at this level, because your nephrologist, your cardiologist and all will not be aware of all these new drugs and what to do. So if they go with a document from the national, guideline, they are also happy to, do exactly as has been told. So always refer back to the book. Your question is a bit complicated. So keep that in mind that, always we can go back to the book. There is nothing to be worried about that.
Good way of knowledge half-day lecture.
Good way of knowledge dissemination.
So we'll move forward. Dr. Rishab, your namesake, Dr. Rishab from Orissa, has asked a question on, suppose a patient develops optic neuritis during treatment, how do you modify the regime without compromising treatment safety, especially in resource limited setting? So Dr. Rishab from Orissa asking Dr. Rishab from Chennai. So the thing is, I assume that this is DSTB, so let us not go into DRTB also.
Sure. So assuming it is DSTB, where the patient is taking the standard HR, ZD, FDC regimen, first thing is ensure that a baseline ophthalmic assessment was done, and it's good practice to do so in general. Once you suspect, or let's say if even confirmed optic neuritis, the first thing would be to stop exposure to the offending agent, most likely to be ethambutol in this case. So then again, FDC is out the window. So when we're suspecting a particular drug to be involved and we're modifying the regimen, we would switch over to individual drugs. And then in this particular case, ethambutol can be substituted with a fluoroquinolone. I'm not sure how resource limited would particularly play into this, but the option would be to give individualized drugs based on the weight for the patient, HR, levofloxacin for the patient. If it is on the off chance DRTB and you're concerned about the BPAL-M regimen and linezolid toxicity for optic neuritis, that would conditionally be on whether the patient has received at least 6 to 9 weeks of linezolid before we can do some amount of treatment modification. Less than 6 weeks, patient develops any linezolid toxicity, typically we abandon the regimen. More than that, there is options for dose adjustment or withdrawing linezolid without compromising the regimen as a whole.
Thank you. Thank you for the short, sweet answer. So we'll move forward. The next question, I think, Dr. Saroj, you can take this. So the question is related to, gene experts showing resistance and LPA not showing resistance. So it's more related to discordance resolution. So can you just tell us in brief
Yes,
about
sir.
how do
So
you do
this is
discordance
a
resolution?
common scenario which we all come across in our field setups. The CBNet is showing resistance and LP is showing sensitive. So as per the guidelines and what we follow in routine is repeat a CBNet also, and the best out of the two we need to select. So a repeat CBNet is must here, and definitely yes, we have to do a culture we have to do a visit culture of all the patients. So culture DST we have to further cross check with the culture DST. So we'll go with the CBNet report, and we'll do a repeat CBNet in this case, and the best of the two will go with the report.
Thank you. We'll move further. Dr. Priti, I'll give this to you. So the question is, in cases where bedaquiline cannot be used due to contraindications, how do you prioritize alternate drugs from group B and C?
This is where bedaquiline cannot be used. The other options that are available are from the group C drugs, because most probably we've used all of the group A and the B drugs. Most of the times we replace bedaquiline with delamanid, but both bedaquiline and delamanid have similar toxicities. Mostly if you're not using bedaquiline, it is either because bedaquiline is resistant or bedaquiline is causing cardiotoxicity. But if bedaquiline is causing cardiotoxicity, then it is unlikely that you will be able to use delamanid as well. We have other replacement drugs like aminoglycosides, we have amikacin, kanamycin. We also have the carbapenem groups, which we use a lot. So maybe we can use Z. We can use ethambutol. So these are the other replacement drugs that we can use if we cannot use better.
Thank you. Thank you, Dr. Preeti. So I think Dr. Rahul asked this question. So Dr. Rahul, if you listen to Dr. Preeti, your question was which drugs you will take from B and C. So for your BPAL M regime and your short MDR regime, there is no replacement. So obviously, when we talk of replacement, you're talking of the longer regime. And the longer regime, we actually used up the group B drugs. So replacement will not come from group B. What Dr. Preeti was telling you, the replacement will come from group C. So the WHO classification, if you see, the group C drugs are in the order of replacement. First drug comes first, ethambutol comes first, and all that. But in India, based on our resistance pattern, our expert committee decided that that order does not work in India. So the order of replacement in India is different. So we all look back to the guideline again. I find it often difficult to remember the sequence as such, even though I could try. But look at the book. Dr. Vikas' presentation had that replacement sequence in his slide, even though the table had the WHO replacement sequence. So you go to the sequence, and one by one, you take drugs. So like Dr. Preeti said, the first replacement drug in our sequence is delamanid. But if it is a QT prolongation, which does not allow bedaquiline to be used, then delamanid also cannot be used. So you go in that way, depending on which drug can be taken. So I think we have answered your question. So we'll move forward. So this question from Dr. Deep is, do we have... Brijesh, are you back to the panel? You had some net connectivity issues.
Yes, sir.
Yeah. So the question is, a patient becomes, I assume that this is MDR-TB, so culture is being used for follow-up. So patient becomes culture negative, but clinically deteriorates. So the question from Dr. Deep is related to culture becoming negative, but clinical deterioration, mismatch between microbiological response and clinical response. How do you deal with it?
So, nice question. So, I think the response of the clinical, microbiological, and the radiological, all this response varies by the time. The timeline is different for all the response. Maybe we have to find out the other causes as well. If the culture is becoming negative, but still we need to complete the total duration of the regimen as well. There may be another infection or other causes of patient not getting well despite having the treatment completion. Not all the time that all radiological, microbiological, and clinical response. But yes, microbiological response is must before completion of the treatment. If microbiological response is not there, then we need to find out the other resistance as well. But radiological recovery and resolution may take time, so as clinical response as well.
Yeah, so thank you for Dr. Brijesh was telling us that each of them is important: clinical response, radiological response, and the microbiological response. And that you have to take everything together, and based on that, you have to make a decision. So we'll go forward. I think because this is more like your question. So, patient has a positive smear, but a negative CB-NAT. What are the possible explanations?
Positive smear, negative CB-NAT, think of NTM, very important. Because smear, to understand, for smear to come positive, more than 10,000 bacilli per ml is must. For CB-NAT to come positive, just 131 colony forming unit is more than sufficient for it to come positive. So if the CB-NAT has been done from a same smear positive sample and it is coming negative, then think of NTM and not TB. But if a smear has been done from a separate sample and gene expert has been done from separate sample, don't think of NTM. Maybe it has come from some different lobe and different segments of the lung. You need to reconfirm it with the same sample. It's very important.
Thank you. Thank you, Vikas. So what Vikas has told you is some same sample versus different sample, and also the possibility of NTM. Just to add, because you had asked what are the possible explanations with the S at the end, I'll just add that other bacteria, for example, we have had cases with nocardia with a smear positive result. So other bacteria can cause a smear positive result. Smear can be false positive. Your NAT can also be false negative. It has a sensitivity of 99%, which means that in about 100 smear positive patients, one could be missed also. So all these possibilities should be considered. If your clinical scenario says that this is TB, and if the smear is positive and NAT is negative, you could even consider MJIT in that patient. So you have to work up the patient also for both TB and NTM. So we'll move forward. I think one question I'll take myself was from Dr. Mehek, who was very rightly pointing out that are we missing NTM cases if we are not sending sputum for microscopy and CB-NAT simultaneously? So what Dr. Vikas was saying, so you're very right. So my part of the country, the program is moving towards molecular technology. So my district in Kerala, currently we have moved 100% to upfront NAT. So we are not doing microscopy at all for diagnosis. So in such a scenario, when all the patients' samples are going only for NAT, we will definitely miss NTM because that smear positive result will not come. But what is being made as a guideline for our state is that if your patient has lesions which persists in the X-ray or clinically, and then if the NAT is negative, in the next time when you actually evaluate this patient, also consider NTM, do send a smear, which would be done as a special case scenario. You might consider taking a sample through a bronchoscopy or something and sending for a culture also. So these things can be done. So we'll move forward with the questions. So where are we? So we'll go to Dr. Priti. I think, Dr. Priti, the question is, can you elaborate on the situation? Dr. Ria from Bangalore is asking, can you elaborate on the situations where you would consider extending therapy beyond the standard 6-month treatment in DSTB?
6 months treatment is recommended for pulmonary TB, but for extrapulmonary TB, especially severe extrapulmonary TB like CNS TB or skeletal TB, we can extend beyond we generally recommend extension beyond the usual 6 months. We can extend up to 12 months. Sometimes in our scenarios, if we feel that, the resolution or the clinical outcome is not optimal, we sometimes do extend to beyond 6 months to 9 months. The other scenarios in which we extend beyond 6 months is if we have suboptimal response, we have sent up for a therapeutic drug level, we see that the drug levels are suboptimal and we have changed our drugs. That is also one of the scenarios where we may extend beyond the 6 months. So definitely yes, for severe extrapulmonary, maybe suboptimal response with a low drug level where we have changed the doses. So in these scenarios, we would be extending beyond the usual 6 months.
Thank you. Thank you, Dr. Priti. I think we are running out of time. We are supposed to close at 10:30. We are already at 10:22. And if there were a few more questions, I would have finished, but the audience has been with us throughout this, and we have maybe about 100 questions left. So there is no way we can finish all those questions. And I'm again apologizing to our audience. I'm thanking them for being so actively involved and for all the questions. But time doesn't permit me to take all the questions which are there. So as a moderator, in interest of time, I'll have to, slowly start winding up this session. So as part of the wind up, can I request our panelists to give one final message which they would like to give to the audience, maybe a point which they wanted to talk on, or maybe a general message to our audience. So I'll start with Dr. Saroj, Meena.
Yeah, so sir, my message on this World TB Day, we are harboring more than 1/4 of the world cases tuberculosis, which is an epicenter of tuberculosis. This is an alarming situation. And likely said by Dr. Vikas, this is not one man's responsibility. This is the responsibility of each one of us. So we have to follow the guidelines. They are freely downloadable at tbcindia.com page. So please follow the guidelines and don't hesitate the patient to refer to a government setup for start of the second line drugs therapies. Do not start treatment by your own, especially in a MDR-TB cases, because that way we are ruining the patient. We are taking away very good drugs from them. And when they reach the government setup after failing or after taking those under optimized regimen for 6 months or 1 year, that is the scenario which we come across daily. And this is actually very heartening. We should not do that. Please refer those patients, not losing those patients from a government setup. You are sending the patient just for the start of those particular drugs which are available only at the government setup. And this is for all of us. Last message, TB is not for the poor disease. TB is no more of the, yes, crowded place has its own risk, but it is no more a disease of the poor. It can affect each one of us, and it is started already affecting many good, well-to-do families also. So please take it seriously, and it's a combined responsibility of each one of us to treat tuberculosis. And feel free to, NITRD has this monthly difficult to treat TB clinic in which anybody can join, can raise your questions. We'll take as much questions as possible, and we are totally dedicated for tuberculosis at a national level. So feel free to join those clinics. And from now onwards, I'll share the link in the ICS group too.
Thank you, Dr. Saroj. So very valid points raised by Saroj. I'm sure there are postgraduates in this webinar. So I'll again reiterate what Dr. Saroj said. So if you go to the NTEP website on the Health and Family Welfare website at the central level, you get all the documents related to NTP. I would also suggest that if you're a postgraduate, please go to the WHO website, the IRIS website. Latest, very interesting documents are there, 2025, 2026. Very good documents, all PDFs downloadable free. So please go through them as well. So we'll move on, Dr. Brijesh, your message to our audience.
So I'll say only a single one-liner that TB, tuberculosis, although it's an age-old disease, it's 100% curable disease. So always stay away from the taboos and myths and all that. So always refer your patient to your nearest physician or pulmonologist or government setup or anywhere. But yes, get the TB treatment as early as possible. And on this TB day, I think no tuberculosis patient should stay without TB treatment in this era of, when our PM is aiming for the elimination of TB. So yes, TB is a 100% curable disease. Stay away from the myths and taboos.
Thank you. Thank you, Dr. Brijesh. We'll move on to Dr. Rishab. Dr. Rishab, your message to our audience.
I think it's basically to expand on what we've previously discussed and to talk about, we're grateful for the advances in pharmacotherapy and the new regimens that are available. But I think it's also important to remember that TB is not only about pharmacotherapy. There's also the whole aspect of the function of the patient, the nutrition, the access to healthcare, the social standards, the housing. So it's multifaceted. So we need to address all of them if we truly want to end TB. Because the problem right now is not that we don't know what to do. We kind of do. But the problem is implementing it in action at every level, right from the tertiary care health center to the grassroots. So I think once that happens, we can get a lot closer to the NTB targets that we're trying to achieve. And hopefully every year we get a little bit closer to that.
Thank you. Thank you, Dr. Rishab. We are out of time. Vikas, 1 minute. I know you have a lot of things to say, but 1 minute. Yeah.
Do not play with patient. Do not play with drugs. We have only 14 drugs. Be clear. Ask experts. No problem. N number of time, but have a right approach. That's very important.
Thank you, Vikas. That was very short from you. So, Priti, your message.
So just have a very low threshold for diagnosing TB and putting the patient on treatment, because we know that early diagnosis has a better outcome. Also see to it that the patient is followed up, thoroughly. As a doctor, have somebody, have a coordinator or a patient caregiver who is constantly coordinating with you, so that the adherence is looked after. So early diagnosis and adherence would be the two things that would help us go a long way.
Thank you. Thank you, Priti. Thank you, all of you. Let me conclude by thanking my excellent set of panelists who did an excellent job today. I enjoyed listening to them, to their replies and all that. And I'm sure the audience would have also really gained from listening to our eminent panel for the day. I also thank the audience for having turned up in such good numbers, big numbers. Tuberculosis is an important disease for our country, and your presence also re-emphasized the fact that we are all concerned about TB. We all need to work together to get rid of TB in our country. Fortunately, like Brijesh just told us, today we have a scenario where the government, all of us together, we are working together towards ending TB. All state governments and the national government are working together. So we have the right atmosphere, and we all have to do our bit to actually manage to end TB in our country. It's a difficult task, but it is doable. So with that, I will conclude the session
On
from
behalf
my
of
side.
everyone, we also thank you for an excellent moderation, sir.
True.
Thank you. Thank you. So with that, I'll close from my side, wishing all of you a good night today, because we're pretty late in the night, and hopefully,
Good night and
many
happy
of your
Parva.
other questions, you get a chance to interact with these experts. Any of us would be ready to, interact with you one-on-one, and you can always reach out to us, because we could not cover all your questions. So with that, we'll close this session for the day. Thank you and good night.
Thank you. Thank you, sir. Thank you
Thank
so
you, sir.
much.
Thank you so much, sir.
Thank you so much. So with
So
that, we are
close.
closing. Thank
Yeah.
you.
Okay. Thank you. So thank you, everybody. I think it went off well. I think you will agree with me. So
Dot on time, 10:30.
So time was important. So I think all of you also, maybe you had some more questions which you would have taken. I would have allowed to listen to you, but I think time doesn't allow that. So thank you, Vikas. फिर मिलते हैं, I think some other place, and
Sure.